Hi everyone, my name is Dan and I'm a mental health pharmacist, and today I wanted to do a presentation on post-traumatic stress disorder. There are four major objectives that I'd like to cover today. So first I want to go into the DSM-5 diagnostic criteria a little bit for PTSD. Then we're going to go into the disease state a little bit more, talk about risk factors, neuroanatomy. Then we're going to talk about treatment options, pharmacologic and non-pharmacologic. And finally, we're going to develop a treatment plan for a patient with PTSD. My presentation will follow these table of contents slides. So I'm going to start with some background information, then I'm going to go more into the disease state itself, and then finally I'm going to talk about evidence-based treatment. So without further ado, let's get into the first section, which is background about PTSD. First, what is PTSD? PTSD is a common mental health condition that develops after a traumatic or stressful life event. This is differed from a normal stress response due to a few factors. One is severity. The severity of PTSD is so severe that it starts to impair someone's functioning. They're not able to function the way that they used to. And PTSD has a long duration of symptoms, so it's lasting symptoms. A normal stress response can happen and does happen after a stressful event occurs. The functioning isn't impaired and this improves over time. But if someone has these symptoms from 3 days to 1 month after the traumatic event, this is called an acute stress disorder. This is the same diagnostic criteria as PTSD other than the timing. So for example, acute stress disorder is from 3 days to 1 month, and then PTSD is when it's 1 month or longer after the stressful event. In both cases, functioning is impaired to be considered a disorder, acute stress disorder or PTSD. Next is the DSM-5 diagnostic criteria. And a good place to start is with the trauma itself. So to meet the criteria for PTSD, there has to be exposure to actual or threatened death, serious injury, sexual violence in one of the following ways. So there has to be a traumatic event. Interestingly, this doesn't directly have to occur to the person. The traumatic event can be witnessed as it occurred to others, or just learning about an event that happened to a close friend or family member can lead to PTSD. Next, the first big cluster of symptoms is intrusion symptoms. So this can be things like recurrent distressing thoughts that are intrusive into someone's mind, recurrent dreams, so nightmares are pretty common, dissociative reactions, so flashbacks, all of these are intrusive events. Next is avoidance. So avoidance is the next big cluster of symptoms. So avoiding thoughts, feelings, people, places associated with the events. So when I used to work at the VA, one of the patients would only feel safe at home, would pretty much board himself up at home, and he was avoiding anything outside because he felt safe at home. So that was like an extreme case of avoidance. Next is negative alterations in cognition and mood. So after someone develops a PTSD from a traumatic event, they will often have distorted self-perceptions, lower self-esteem, negative thoughts, depressed mood, all sorts of things like that. And the final big cluster is hyperarousal, hyperreactivity. So hypervigilance, exaggerated startle response, problems with concentration. Again, when I worked at the VA, I went onto the PTSD unit one time and I set my book down a little more loudly than I meant to, and every vet jumped that was in the room. So showing that exaggerated startle response. So a way that I remember the symptoms is through, the way that I remember a symptom cluster is through a Marine battle cry called oorah. So sometimes you'll hear Marines saying oorah to each other. So I associate this with PTSD because it helps me to remember the big symptom clusters. The R is re-experiencing, the A is avoidance, and the H is hyperarousal. So then the only other big cluster you have to remember is the negative symptoms. So a traumatic event has to happen, then re-experiencing, avoidance, hyperarousal, negative symptoms. These are the big symptom clusters of PTSD. Measurement-based care is really important. So these are often subjective symptoms. So putting an objective number or score to the severity of someone's PTSD can be quite helpful. The most commonly used scale and considered the gold standard is the CAPS-5. This is a structured interview, 30 items, clinician-administered scale. So I hope that background was helpful in talking about what is PTSD and how is it diagnosed. Now I wanted to go into risk factors, disease progressions, and a little bit more about the disease. So in the general population, 6.1% in a pretty large sample size of people had PTSD. So this is a pretty common disorder that affects a lot of people. Higher prevalence in women than men. In active duty veterans, the numbers vary greatly. So some studies show pretty low amounts and other studies show up to 17% of people develop PTSD. So that's quite high. Here again, higher prevalence in women than men. There's certain factors related to the trauma and before the trauma and after the trauma that can be a risk factor for developing PTSD. First is the pre-traumatic factors. So there is a genetic risk of developing PTSD. Some people are more prone to develop PTSD than others. Next is gender. Females are more likely to develop it. Next is age, and it seems that the extremes of age are what matters the most. So really young people who experience a trauma and really old people are most at risk. Next is prior trauma. So people think that prior trauma can build a resilience against PTSD, but this doesn't seem to be the case. Multiple prior traumas is a risk factor for developing PTSD. Some factors related to the trauma itself is the severity. So a really severe trauma is more likely to cause PTSD than a less severe trauma. Perception that life is threatened is another risk factor. And then disassociation during the traumatic event is associated with a higher prevalence of developing PTSD. Post-traumatic factors involve social support. So a lack of social support is not helpful in someone who has the risk of or is developing PTSD. Next is pathophysiology, and this starts with the HPA axis. So this is the hypothalamus, pituitary gland, and adrenal gland, and this is active during a lot of different anxiety states. And what this causes is the release of cortisol, which is a stress hormone. So you might be surprised to see that in PTSD, cortisol levels are lower than normal. And this is attributed to something called chronic adrenal exhaustion. So your HPA axis is activated for so long, producing cortisol for so long, that it kind of runs out of steam and cortisol actually decreases a little bit. The sympathetic nervous system is more reactive, and this is highlighted by that hyper-responsiveness to sounds and movement and all sorts of things. Next, alpha-1 and alpha-2 receptors are associated. These are overactive and can activate the sympathetic nervous system and norepinephrine as well. So some staging that's proposed for PTSD is stage 0 is the traumatic event occurs. Then stage 1, the patient might start to develop some symptoms. So this is kind of like that acute stress disorder starting to form. Stage 2 is they meet the full threshold for symptoms, so this would be acute stress disorder. Then stage 3, if the symptoms persist, this would be classified as PTSD, and then stage 4 would be severe remitting PTSD. So now let's go into the most important part from a pharmacist perspective, which is the treatment. How do you treat PTSD? We're going to start with the VA Department of Defense guidelines that were released pretty recently in 2023. First line option in these guidelines is trauma-focused psychotherapy. So there's different types that are available. There's cognitive processing therapy, eye movement desensitization and reprocessing, and prolonged exposure. And what these exposure-based therapies do is over time, when you talk about the event or think about the event, you have a really big stress response. But over time, as you continue to do it, it gets a little less, a little less, a little less, until you're able to function better. After first-line options, which are non-pharmacologic, are second-line options, which are medications. So selective serotonin reuptake inhibitors are a first-line medication option, but second-line to the therapy itself. The VA guidelines specifically recommend paroxetine and sertraline, as these two are the most studied in PTSD and have the FDA approval for the treatment of PTSD. They also list an SNRI, serotonin and norepinephrine reuptake inhibitor, venlafaxine, as a second-line option, and this is not FDA approved for PTSD. Finally, they have a weak recommendation for prazosin for nightmares itself, not for other symptoms of PTSD. So these medications are often the starting place after therapy or with therapy. Potential third-line options. So the VA is saying that there's not enough evidence for or against, and you'll see the other SSRIs, the other SNRIs, tricyclic antidepressants, but the other is the most interesting thing that I found here. So they have things like mood stabilizers, lamotrigine, antipsychotics like olanzapine, quetiapine, but they also have things like psilocybin, ayahuasca, DMT, LSD. So it's interesting to see the VA guidelines not being against these federally controlled substances and showing that maybe they will have some potential use in treating PTSD in the future. The VA guidelines are helpful because most guidelines recommend how to treat something, but they don't necessarily tell you what not to do. And these VA guidelines do. They recommend against certain things. So they have weak recommendations against these listed here, including augmenting treatment with antipsychotics. In real practice, you will often see antipsychotics used in patients with PTSD, so it's important to note that the VA guidelines recommend against doing this. They also have a strong recommendation against benzodiazepines and cannabis, so these seem to have negative evidence when it comes to PTSD. Probably the best theory as to why is that the best treatment we have for PTSD is these exposure-based therapies. And if someone is kind of sedated or kind of out of it on benzos or cannabis, they're not going to have that stress response that you can diminish over time. So cannabis and benzodiazepines may negate our best treatment that we have for PTSD. I think there's some potential for nuance here in the future, looking at different cannabinoids rather than cannabis as a whole, but currently in the guidelines, it's a strong recommendation against. There are additional guidelines outside of the VA guidelines, so I wanted to highlight these as well. They're relatively similar in that they have trauma therapy and CBT as options. They differ a little bit in that SSRIs, they just say pick any of them. They don't necessarily specify paroxetine and sertraline. They do have SNRIs and they do have a few other options as well. So a quick question, which of the following SSRIs would be most appropriate to start for a patient with PTSD at a VA hospital? So feel free to pause, think about it, and according to the guidelines, sertraline and paroxetine are the ones that they have, so it would be sertraline. Which of the following is recommended against in the treatment of PTSD in the VA guidelines? So remember, for ayahuasca, DMT, and LSD, it was saying there's not enough evidence for or against, but the guidelines do recommend against cannabis and benzodiazepines at this point. So cannabis is the answer. Now let's go a little bit more detailed into these exposure-based therapies. So first we're going to start with cognitive processing therapy. This is a really interesting type of therapy where you start with psychoeducation, connecting emotions, thoughts, feelings to physical symptoms, but then you have the participants write and read what's called an impact statement. So this is, in their own words, a description in detail of what they think is causing their PTSD. So it's writing the traumatic event out in detail. Then the patients read this impact statement to other participants in the cognitive processing therapy. And you will see that when I saw people doing this, they would be shaking with anger as they were reading their impact statements. So you can really see that anxiety, emotional response that's activating. But each time you talk about this impact statement and each time you talk about the event, you start to be able to modify this maladaptive thinking, realize that you're safe, recognize that you're safe, take away guilt, take away blame, and it gets easier and easier to talk about the trauma. Next, an interesting therapy is called eye movement desensitization and reprocessing. So when a traumatic event happens, it's kind of stored not normal in the brain. It's kind of stored jumbled all over the place. Whereas regular memories, non-traumatic memories, are stored more linearly. So what this therapy involves is the therapist will either move their finger or move a light, and you'll move your eyes while you think about the event and know that you're in a safe environment. And over time, you're able to kind of reprogram that memory and have less of a stress response. So the theory of this is kind of based on REM sleep. So during REM sleep, your eyes are moving all over the place, and eye movements can trigger memories. So your dreams are often these random assortment of triggered memories that your brain is trying to make into a cohesive story. So when you're moving your eyes, you're forming new memories while thinking about the event and knowing that you're safe. So over time, this decreases the effects of the anxiety response. Finally is prolonged exposure therapy. So this is quite uncomfortable to start because you're forcing the person to face or deal with or talk about whatever they found traumatic over and over and over. And eventually you diminish that anxiety, flight or fight, sympathetic nervous system response. So now for medications. Sertraline and paroxetine are both FDA approved for PTSD, and these are the two that are recommended in the VA guidelines. How I remember this is in the letters PTSD, there's SSRIs that start with P and S, paroxetine and sertraline. These are the two that are FDA approved here. They have the same warnings and side effects that you'll see when using these meds for major depressive disorder, generalized anxiety disorder. So that increased suicidality box warning in those age 24 or younger, headaches, GI distress, serotonin syndrome, sexual dysfunction, discontinuation syndrome. So a lot of side effects to counsel your patients on. A study by Zollner and colleagues compared prolonged exposure to sertraline, and they found that both were effective. The prolonged exposure seemed to do a little bit better, and the participants in this study preferred the prolonged exposure therapy over the sertraline. So this kind of coincides with our guidelines that are saying start with therapy and then choose a medication second if needed. Venlafaxine is not FDA approved, but it is a first-line option, and these are going to be the same side effects with venlafaxine that you'll see in MDD, generalized anxiety disorder, other indications. So similar side effects to the SSRIs, but the norepinephrine component adds high blood pressure, maybe some more sweaty palms, things like that. Next is prazosin. So prazosin is an alpha-1 blocker that's used for the treatment of high blood pressure. Interestingly, they found that overactivation of alpha-1 receptors in PTSD and found that prazosin may help to decrease just the nightmares component of PTSD. So when I used to work at the VA, I would see prazosin used all the time. Generally, the patient would get 1 milligram at night. If they still had a nightmare, they would go to 2 milligrams. If they still had a nightmare, 3 milligrams. If they still had a nightmare, and so on. They would keep going up. The thing you worry about with this medication, though, is it is a blood pressure medication, so you're worried about dropping someone's blood pressure too much. This plays a role as well because prazosin is taken at night before bed to help with the nightmares. So if a patient has to get up and use the bathroom in the middle of the night, you want to counsel them on getting up slowly, so they don't get that orthostasis and fall. Here's a New England Journal of Medicine trial that showed really not a big effect of prazosin in decreasing nightmares, but there is a little evidence that it can be helpful, so the VA guidelines has this as a weak recommendation. So which of the following would you recommend for a patient recently diagnosed with PTSD with extreme nightmares? So feel free to pause and think about it. So the best answer is EMDR therapy is a first-line option, along with prazosin for the nightmares. Okay, so we went into some of the background of PTSD. We went into the disease state a little bit more, and then we went into the guidelines, especially focusing on the VA guidelines with their first line options of therapy, their second line options of medications like specific SSRIs, venlafaxine, prazosin for nightmares, and then we talked about what the VA guidelines say not to use, so benzodiazepines and cannabis. Hopefully that met the objectives, and I hope this presentation was helpful. Thank you.